Welcome to this presentation on the EPI Check Inject. I'm Tom Dardis, the Operations Manager for Woods Ambulance. This class is being offered to meet the biannual requirements set forth by Massachusetts OEMS. There will be a practical component to this class, and you will not receive continuing education credit until you complete that component. I have no conflicts of interest to disclose. However, I will note that while specific trade-named items will be referenced here, I am not endorsing any of them. These items just happen to be what is currently carried by Woods Ambulance at the time this presentation is being made. At the end of this presentation, there will be a short assessment quiz for you to complete. Through this presentation, we will discuss identifying anaphylaxis and assessing the need for an epinephrine injection. We will cover the various protocols for the use of epinephrine in both anaphylaxis and specific respiratory conditions as allowed by the state of Massachusetts. As stated, there is a practical component to this class, and you will receive correspondence shortly if you haven't already on how to complete that component. An allergic reaction is an abnormal immune response to a foreign substance. But when does this graduate into anaphylaxis? The World Health Organization defines anaphylaxis as a severe, life-threatening systemic hypersensitivity reaction characterized by it being a rapid onset with potentially life-threatening airway, breathing, or circulatory problems, and is usually, although not always, associated with skin and mucosal changes. The Mayo Clinic defines anaphylaxis as a severe, life-threatening allergic reaction. A good rule of thumb is how the ASCIA, which is an Australian health organization, defines it as a life-threatening reaction causing upper airway obstruction, bronchospasm, and/or hypotension. Hives develop when there is a reaction that activates immune cells in the skin, called mast cells. When activated, these cells release natural chemicals. One important chemical is histamine. When histamine is released into the microvessels, or capillaries, it causes vasodilatation, creating the reddened welt that we see. That dilatation also causes fluid to leak out of the vessel and creates the swelling that we see. Because it doesn't always occur during an allergic reaction or anaphylaxis, we cannot rely solely on its presence or absence to make a determination one way or the other. In other words, just because they're not there doesn't mean it's not anaphylaxis, and just because they are there doesn't mean that it is anaphylaxis. Hives can be caused by both acute and chronic conditions, and they can either be systemic or localized. This furthers the need to ensure a proper physical exam. Hives are present, however, in up to 90% of anaphylactic cases. As you can see in this photo, angioedema can end up looking pretty impressive. But what causes it? Angioedema is caused by a rapid increase in permeability of submucosal or subcutaneous capillaries and postcapillary venules with localized plasma extravasation. What does all that mean? Well, simply put, the vasodilatation allows fluid to leak out of the vasculature and third space, causing the edema that you see here. Most causes of angioedema are dependent upon the release of either histamine or bradykinin. Other vasoactive substances may be contributory, but we're not going to cover those today. So basically, what we're saying is the same vasodilatory effects of histamine that cause the hives can cause enough capillary leakage to create the angioedema. It is seen in the face and in the eyes, and may even swell the eyes shut. This can become severe enough to extend to the upper airway, including the tongue, either of which can cause obstruction. The severe restriction can be heard in the form of stridor. Because of the edema, a patient may experience dysphagia or difficulty swallowing, and therefore may even drool. Angioedema is present in up to 60% of anaphylactic cases. So now we'll move on to bronchospasm. Histamine, again, is the primary reason. As histamine is released, it stimulates the H1 receptors in the smooth muscle of the airway that creates bronchoconstriction, secretion, and increased mucosal edema. This manifests into severe difficulty in breathing, decreased SpO2s, and the stereotypical shark fin pattern seen with bronchospasm in a capnograph pictured here. Dyspnea and wheezing are present in up to 50% of anaphylactic cases. Hypotension is probably the most underappreciated or overlooked sign in anaphylaxis. It may even be one of the early signs seen in the condition. It's caused by histamine. Seeing a pattern here? As previously discussed, histamine activates the H1 receptors that causes leakage and swelling. But that's not what causes the hypotension. That same receptor is said to release a chemical known as nitric oxide that causes smooth muscle relaxation. The majority of your vasculature is smooth muscle. That chemical release, combined with the sympathetic relaxation of vascular tone, creates a relative shock state and thereby hypotension. Hypotension is present in about 35% of cases. Combined, hypotension, difficulty breathing, and angioedema are seen in up to 80% of cases. This is why we don't wait to treat anaphylaxis until the presence of hives, nor difficulty breathing alone. If a patient has been exposed to a known allergen and is experiencing hypotension, then consideration of epinephrine is indicated. When in doubt, medical control is always your best option. Protocol 6.5 is the Massachusetts OEMS protocol that outlines the check and inject criteria. It is a medical control option that a service can choose to be part of in lieu of using an EpiPen. The current cost of a standard EpiPen is listed as up to $750, where the cost of a check and inject kit is but a few dollars. Hence, why many services have elected to go with this option. The kit is maintained in its own container in order to keep the medication separate from other medications in the BLS repertoire. The epi that is in the case is not meant for intravenous use in its packaged form, and the vial must be labeled as such. Each kit will have one vial of medication which comes in a 1 to 1,000 concentration for a total of 1 milligram in 1 milliliter of solution. 2 sterile 1 milliliter safety needle syringe combinations. This needle syringe combination type has the needle permanently attached to the syringe and cannot be separated. There should be directions in the kit outlining directions for use, reiterating the not for IV use warning, and dosages for both adult and pediatric patients. Note that the state delineates the use of a pediatric dose from an adult dose using a patient's weight. If your patient is less than 25 kilograms or 55 pounds, then use the pediatric dose of 0.15 milligrams, also 0.15 milliliters. And if they're over 25 kilograms, then you use the adult dose of 0.3 milligrams or 0.3 milliliters. When looking at the protocol for 2.2a, which is the adult, and 2.2p, which is the pediatrics, the overall premise is essentially the same. In the presence of anaphylaxis, epinephrine is a standing order. However, note that medical control must be contacted for patients that are under 6 months old or over 65 years old. The dose is where you need to pay close attention. For your pediatric patient under 25 kilograms or 55 pounds as discussed earlier, you will use the 0.15 milligram dosage, and again your adult dose is 0.3 milligrams. In addition to the epinephrine, diphenhydramine or Benadryl can also be given. The dosage in the adult for the Benadryl or diphenhydramine is 25 to 50 milligrams of the oral liquid or pill, where the pediatric again is weight-based at 1 milligram per kilogram for kids 2 years old or older, up to 25 milligrams. The liquid is generally preferred, but if your pediatric patient is willing and able to swallow pills, that does remain an option. You do not give Benadryl to kids under 2 years old as a basic provider. Please be aware that the patient must be able to adequately swallow on their own before administration. Also note that neither the adult nor pediatric protocol for anaphylaxis gives you the ability to use albuterol or other bronchodilators under these protocols. If you look closely at the critical criteria listed at the bottom of both of these, they outline the signs to watch for to help you facilitate your decision to use the epinephrine. Bronchospasm was listed as a sign for anaphylaxis. As you well know, it is also something that occurs in patients with asthma or COPD. Under the medical control option for the EPI Check Inject, BLS providers can administer epinephrine in isolated bronchospasm in severe cases. Unlike the anaphylaxis protocol, 2.6 has differences with regard to when the epinephrine can be used. In the adult patient with severe distress, and we'll go over severe versus mild distress in a later slide, the use of epinephrine is only by medical control order versus being standing order in the pediatric population. The use of epinephrine in a pediatric patient under 25 kilograms or under 55 pounds is 0.15 milligrams or 0.15 milliliters, just as it is in anaphylaxis, and remains restricted to children over the age of 6 months. Once the child or adult is over 25 kilograms or over 55 pounds, then you switch to the 0.3 milligram or 0.3 milliliter dosage. The state of Massachusetts defines a pediatric patient as under 14 years old, so children over the age of 14 are treated under the adult protocol, which will require medical control consultation prior to administration. Bronchodilators can also be used under this protocol, but will be covered in a separate presentation. In the case of bronchospasm without anaphylaxis, it is important that you distinguish the difference between mild and severe distress. While in both levels of distress bronchodilators are indicated, epinephrine is only used in severe distress. Remember, the use of bronchodilators is not allowed for BLS providers under the anaphylaxis protocol, and this presentation is only discussing the use of epinephrine. These excerpts are taken directly from the pages of the Mass OEMS statewide treatment protocols and can be viewed online or downloaded for you to review at any time. Signs and symptoms of mild distress may involve wheezing, tachypnea, maybe even mild tripoding or simply leaning forward, and they may be speaking in near full sentences, but are otherwise in stable overall appearance during your exam. Severe distress progresses to tripoding with the elbows out to allow for better chest expansion, 2 to 3 word sentences or they may be completely aphasic, a decrease in color or pallor, even to cyanosis, whether circumoral, peripheral, or systemic, and or altered mental status due to hypoxia or hypercapnia. These circumstances require quick identification and treatment. Silence is not golden. There's an old schoolhouse rule that silence is golden. What might have been good for grammar school is not good in this case. When bronchospasm becomes severe enough, a patient stops wheezing because there's not enough air movement to even produce the sound, let alone support consciousness or life for very long. This rule applies to anaphylaxis as well as isolated bronchospasm. Clearly, in either case, you must request ALS if it hasn't already been done by dual-tiered response, but do not delay transport while waiting for ALS to arrive. Regardless of the medications you administer, be prepared to manually ventilate with a BVM in a patient with severe distress. In some pediatric cases, the use of a BVM might even provide better oxygenation. As with any medications, there are pearls and pitfalls. Use caution in patients over 40 with previous cardiac histories, since the epinephrine can cause increased workloads on the heart and produce negative effects. So now you know when to give epinephrine, but why does it work? This chart has more information than we need for this presentation, so we will concentrate on the need to knows. Your pulmonary and cardiovascular systems contain alpha and beta receptors. Epinephrine is an alpha and beta agonist. The alpha-1 receptor will increase vasoconstriction and peripheral vascular resistance, increasing your blood pressure while reducing mucosal edema. On the beta-1 side, it increases inotropy, or the force exerted by a squeezing heart, and increases chronotropy, or increases heart rate. Both contribute to increased blood pressure. The beta-2 receptor in the pulmonary system causes bronchodilation, thereby opening up the lower airways to improve ventilation. I know what you may be thinking. Why does this chart say vasodilation and vasoconstriction? Well, in very small doses, smaller than the doses we're talking about in this presentation, epinephrine can cause the opposite effect. Every service will likely have a variation of the intramuscular injection kit. Every kit should show an expiration date and be labeled conspicuously to show that the epinephrine within is not for intravenous use. Under the Massachusetts OEMS Statewide Treatment Protocol 6.5, the epinephrine must be kept in a separate container from all other medications, hence why you will likely find a separate kit like this if you are not deploying an EpiPen autoinjector. Each kit will contain a single vial of 1 to 1,000 epinephrine, which equates to 1 milligram in 1 milliliter, which in itself will be labeled to reiterate the not for intravenous use directive. Instructions on how to draw and administer using the enclosed syringes, what to monitor for and document, and in some cases, as pictured here, have the protocol as a quick reference guide for your convenience in what is likely to be a high-stress moment. Before giving any medications, we should always use this checklist referred to as the 5 rights or 5 R's. Make sure you have the right patient. In the case of EMS, this is generally easy as we only deal with one patient at a time under normal circumstances. If you're working in a setting where you're overseeing multiple patients at a time, such as in a hospital, urgent care, or MCI setting, you can see why this is the first item on the list. Next, make sure you have the right medication. Since the epinephrine in this kit is separate from other medications, this should be easy. But don't get complacent. Did you put the kit together? How do you know the person who made the kit didn't accidentally put in the wrong one? Medications are sometimes packaged in identical containers with the same colored labels or caps that can make mixing them up all too easy, especially if they come from the same manufacturer. So always read the label. Note that sometimes medications may be labeled with a generic or trade name as seen here, where adrenaline is the trademarked name and epinephrine is the generic name. It is considered best practice that the person who drew up the medication is the person who gives it. If someone else draws up the medication and you didn't verify the right medication was drawn, you as the administrator are responsible for those consequences. The right dose. Within these kits are labels to show the adult and pediatric doses. Remember, less than 25 kilograms or 55 pounds is the pediatric dose. The following slides will show you how to properly measure your medication draw. The right route. This refers to the proper route of administration. In the case of epinephrine, you as a BLS provider will always give it as an intramuscular injection. An EpiPen autoinjector is always used mid-lateral thigh as recommended by the manufacturer. With the Check Inject, you may use other sites, but only if trained to do so. Here we'll discuss the IM injection for the deltoid muscle, or the lateral shoulder, and the lateral thigh. The right time. Initially, and for the purpose of this protocol, the right time will be based on your continuous physical exam of the patient you have before you. Time becomes more of a consideration for additional doses as directed by medical control. Remember, your second dose is standing order under the anaphylaxis protocol after 5 minutes, but medical control must be contacted for use with isolated bronchospasm after the initial dose. There can arguably be 2 additional rights to this list. The right allergy status refers to making sure that you check with your patient on what allergies they possess. This is true for any medication you administer to a patient. And the 7th is sometimes the most overlooked, the right documentation. Whenever you give a medication, take note of the patient's condition that led you to the decision to give the medication, the time you gave it, and the results after you gave it. In other words, what effects did you witness? Did the patient improve their color or pallor? Did their breathing become visibly easier? Does the patient admit to improvement or complain of worsening of their condition? And don't forget your pre and post vital signs. Many medications have side effects. Some, like EPI, have hemodynamic effects that will show in their vital signs and are very important to assess for on a continuing basis. Once you have determined the need for the epinephrine and you have opened the kit, look at the vial of medication and apply the relevant portions of the 5 rights by checking to make sure it is the right medication and that it is not expired. Note the not for IV use label. When viewing the medication, look for any foreign debris or floaties of things that should not be in there. The medication should be clear and colorless. Check the cap to make sure the medication has not been tampered with. If you find anything of concern, then discard the medication and retrieve another kit. The same goes for the syringe. It should be of the type that does not allow for the separation of the needle and barrel of the syringe. In this case, Vantage Point is a brand where the needle retracts into the barrel after the administration of the injection. Look at the expiration date and the overall package integrity, noting for rips, stains, discoloration of the syringe, or is otherwise compromised. When you open the syringe, you will notice that the graduated scale on the barrel shows that when it's full, it's equivalent to 1 milliliter. In this protocol, you need to use this type of syringe because of the finite dosing required for administration. Larger syringes will not be as accurate in these smaller dosages. Each of the smaller hash marks is equal to 0.01 milliliters or 1/100th of a milliliter, sometimes also referred to as cc's. A cc is a cubic centimeter, so 1 cc is equivalent to 1 milliliter, and therefore the terms can be used interchangeably. To determine how much you have in a syringe, you align the stopper at the tip of the plunger with the bottom of the hash mark that reflects the dosage you will need in milliliters. In this example, you can see that the syringe is set at 0.3 milliliters. Some syringes have a domed shaped stopper. In that case, you align the flat edge of the stopper that is in contact with the barrel of the syringe in the same manner as previously discussed. When inspecting the vial, the cap should still be attached to the vial and is able to be spun if you twist the cap. This is just a quick way to check the vial for tampering. And in case you didn't notice, there is a not for IV use reminder here as well. The cap is secured to the vial at the septum, between the flange of the vial and the cap, as you see here. When removed, it shows the non-latex rubber stopper where the needle will penetrate the center of the vial atop the flange. Do not touch the stopper, as it is considered to be sterile. If the sterility of the stopper is compromised before withdrawing the medication, use an alcohol pad to decontaminate it prior to contact with the needle. Keep the syringe capped until you're ready to perform the injection. Do not recap a needle. Draw back on the plunger until the stopper is at the amount you wish to withdraw. It is often good practice to withdraw just past the desired dose worth of air, which we will demonstrate later. Pull the cap from the needle, and do so in a smooth single action. Attempting to pull the cap gingerly can cause you to accidentally have an unprotected, self-administered needle stick. Do not recap the needle. Doing so increases the risk of a needle stick. Pierce the center of the vial stopper with the needle. Be very cautious if you are doing this in a moving ambulance to avoid an accidental needle stick. One technique is to anchor your syringe hand to your vial hand as shown here. Caution still needs to be taken to avoid a needle stick and to avoid contaminating the needle itself prior to the injection of the patient. Push the needle through the vial stopper and inject the air you pre-selected from the syringe. Before withdrawing the medication, make sure the bevel of your needle is below the fluid line, so you don't withdraw air into the syringe. A vial is a sealed container with no ventilation. If you try to withdraw medication without injecting air, you may have trouble getting the amount of medication you need. A vacuum is created as you draw back on the plunger of the syringe. So if you don't replace that space with air, it will hamper your ability to withdraw the medication from the vial. In an earlier slide, we spoke about drawing up more air than the amount of medication needed. When you draw the medication into the syringe, you will likely get some air. Pulling in a little more medication than needed will help in setting the right dose momentarily. Keep the needle in the vial after you draw up your medication. You can see on the left that air has found its way into the top and bottom of the barrel of the syringe after the medication has been drawn. Flick the syringe to get the air to collect at the top of the syringe. Once the air is at the top of your syringe, you can inject it back into the vial. Then adjust your plunger to the desired dose as you see here. Double check to make sure you have the right dose that you require. Here, you can see the edge of the stopper at the 0.3 milliliter line, which would be the adult dose of epinephrine in the prescribed 1 to 1,000 concentration carried in the Check and Inject kit. We will discuss the pros versus cons of deltoid injection versus quadricep injection momentarily. First, we'll discuss how to find the landmarks for the deltoid injection. The deltoid is a triangular-shaped muscle located to the proximal lateral aspect of the upper arm. It allows for your arm to be abducted outward from the body. Finding the landmarks and ensuring you inject the site properly keeps you from accidentally injecting the medication into a blood vessel or spearing it through a nerve bundle. Doing so can create unnecessary pain and, worse, if injected into a blood vessel, can have severe cardiovascular side effects up to and including cardiac arrest. The injection site is in the middle lateral aspect of the deltoid muscle. Too posterior or distal, and you can see how dangerously close you get to the major blood vessels or muscle insertion sites where tendons reside. Too high, and you risk hitting the AC joint or tendons. One quick method, as shown on the right, isolates the area to target. Find the AC joint and place 2 fingers down from there. With your other hand, form a V in the middle of the deltoid underneath your underhand. The area in the middle is your injection site. When using the quadriceps, the lateral aspect of the upper leg is used as shown here. So why choose one site over the other? Let's first talk about the pros for the deltoid. Its ease of access. The deltoid is easy to get to whether your patient is conscious or unconscious, especially when they're on the ambulance stretcher. It's easier to decontaminate the site prior to injection, even in an emergency. The biggest con for the deltoid is that it is a smaller target area, therefore you have to be more cognizant of your injection method. How about the biggest pro for the lateral thigh? It's exactly that. The large muscle gives you a bigger injection target. Therefore, you're less likely to accidentally hit a nerve root or major blood vessel. The biggest con for the lateral thigh is that it is often covered with clothing. This makes it difficult or impossible to properly decontaminate an injection site, especially when the patient is having severe distress. Improper injections may also occur if you forget to empty the patient's pockets prior to attempting to administer the medication. Finally, it's harder to get to when in confined spaces or on the ambulance stretcher. When injecting with an auto-injector, general practice and the manufacturer recommendation is to simply shoot it through the pant leg material, and any infection concerns will be dealt with later. Every effort should be made to at least clear the injection site of bulk contamination, such as mud or other debris, before medication administration. Using the enclosed alcohol pad, and if the patient condition allows, clean the intended injection site, starting at the center of the site, making a circular motion in either clockwise or counterclockwise direction, working outward from the center to an area of about 2 inches, and allow it to air dry if possible. There are several types of injection methods. For the case of epinephrine, intramuscular is the preferred depth. Muscle maintains a higher absorption ability than subcutaneous or skin tissue because of the larger amount of circulation noted to be in the muscle. In a shock state, peripheral shunting may further limit absorption closer to the surface. Better absorption means faster onset time of the medication. The IM injection is done at a 90-degree angle to the surface of the skin. The syringe may be held like a dart, but we don't wind up and stab the patient like one. Place the thumb and forefinger on your non-dominant hand on either side of your intended and decontaminated injection site. Push the skin in and spread your fingers apart to pull the skin taut. This compresses the skin and adipose tissue to aid the needle to its intended depth. Use caution in a moving ambulance when doing this to avoid accidentally stabbing yourself with the needle, causing an unprotected exposure to yourself or your patient. If at any point you experience a contaminated needle stick or cause one to your patient, make sure you document it in accordance with your company's bloodborne pathogen exposure policy. At the pre-discussed 90-degree angle to the skin, with your dominant hand, drive the needle into the injection site until the hub or base of the needle is against the skin. You do not need to push the needle hub into the skin, just flush with the skin. Hold the syringe steady with your dominant hand at the same angle it entered the patient. With your non-dominant hand, grab the plunger of the syringe and aspirate or pull back slightly. Watch the hub and syringe to make sure you did not pull back any blood. If you do have a positive aspiration sign, do not inject the medication. This likely means your needle is in a blood vessel. Abort the injection and begin again with a fresh kit or needle draw. If injected into a blood vessel, this concentration of epinephrine will cause tachycardia or other tachydysrhythmias such as ventricular tachycardia or even ventricular fibrillation in worse cases, as well as hypertension. Even when given properly, you may still have some tachycardia, the shakes or tremors, anxiety, or even hypertension. This is why caution is advised in those aforementioned age groups or those with pre-existing cardiac conditions. After confirming you are not in a blood vessel, use your non-dominant hand to inject the medication. If you are using a vantage point style needle like the one pictured here, push the plunger all the way to the collar of the syringe behind the flange. This will cause the spring-loaded safety mechanism to activate, retracting the needle into the barrel of the syringe. After the medication has been administered to your patient, dispose of the syringe needle assembly into an approved sharps container. There may be some minor capillary bleeding from the injection site, so simply cover it with the enclosed Band-Aid. Now for everybody's favorite part, documentation. As with all assessments and treatments, we need to document the outcomes of those interventions. As a general rule, document your 5 rights to show that you actually use them. Note the time of medication administration and the vital signs you had pre- and post-treatment. Remember to give it a few minutes to give time for the medication to work. The onset, depending on the patient's severity and physiology, can take up to 5 minutes before the effects of the medication can be observed. Remember to properly document your patient assessment to show how you arrived at your decision to use the epinephrine. Does the patient admit to feeling improvement? Did they remain status quo or complain of feeling worse? And document what those complaints are. Use your assessment skills. Some of the post-administration complaints may be expected side effects as opposed to worsening of their condition. For Wood's Ambulance, this accordion quick reference guide is in each kit along with the previously mentioned protocol cards. Every kit should have a similar set of instructions for use. As stated in the beginning, there will be a short exam following this video. If you have any questions, contact your clinical or education coordinator. With that, I'd like to thank you again for your participation in this course. Contact your clinical or education coordinator to complete the practical portion of this class in order to receive continuing education credit and fulfill the Mass OEMS state requirements.